So this is, I want to welcome all of you to the Beckman Laser Institute. This is our first seminar, in-person seminar since the pandemic. So it's a real pleasure. And we also have remodeled the library here, and it looks a lot nicer than if you were here before. And it's my pleasure to introduce our speaker today, David Chalyan. He received his doctor's in medicine at the Roy and Lucille Carver College of Medicine at the University of Iowa. And then he came here to University of California and got a master's degree in biomedical engineering. He studied with, I think, Wasabi, Dr. Malloy, everything coronary. So hemodynamics, fractional flow reserve, diastolic fractional flow reserve. So all the techniques that are used to characterize flow in the coronaries. So he's currently in the Phillips Chief Medical Office. He's a safety officer and also leads the clinical development for image-guided therapy devices. And today, David's going to talk about some of the studies he designed to demonstrate the utility and the effectiveness of IBIS. One of the challenges in developing these new procedures is just to get clinicians to adopt them and use them. And everything is evidence-based. So David has actually designed these studies to demonstrate the effectiveness of the different techniques. So let's welcome David.
So thank you, Tom, for a very warm welcome. I'm really delighted to be back here at the Beckman Laser Institute. I've been here as a graduate student many different times for lectures. I think that was back when Stephen George was still with the department. So I remember really interesting lectures and really fruitful discussions. About myself, as Tom mentioned, I come from a coronary physiology background, and more recently I've expanded into the intravascular imaging, given there's a lot of overlap and synergistic opportunity in the diagnostic adjunct space. So for me, the endovascular intervention space was a prime opportunity to basically to translate both technologies. So full disclosures, yes, I currently do have an appointment with image-guided therapy as clinical development director. And I'm also on the safety office side. I get to see a lot of crazy things that typically a lot of practitioners don't get to encounter, and different ways that devices can fail. So essentially, I have to think hard about scenarios where everything could go wrong in the procedure. So again, safety first. I really want to stress that as an important topic, just because how much I really appreciate the analogy from the airlines and how much that really applies to the procedural space, with the physician, of course, is at the center of it. So if folks that are joining from the medical center, especially younger investigators, if you do get a catheter stuck at a place it shouldn't be, just make sure you page surgery, phone a friend if you need to. Don't discharge the patient and have them drive to somewhere where you have privileges, and things could go snowball from there. So that's actually been done before. Also, if you are a clinical researcher going into industry, just remember that you kind of are the barrier between patient safety and really are on the side of the patient to protect them. So make sure you speak up and know who your safety officers are in the organization. That's the most important thing. You have to know, see something, say something, but know who to say it to. And so I think I welcome you to see who your safety officers are on that side. In terms of this is actually a really good example that I got from Arnold Cito, who's at the Long Beach VA. He studied under Mort Kern, and this was at the Cath Lab Essentials Conference in 2015. But I remember him giving, that was the first time I encountered that analogy. And the important thing from there, he gave an example of the Tenerife Spanish island crash in 1977 when an airplane pilot did not have clearance to take off, ended up ignoring the air tower, and the co-pilot warned him once, but ended up both planes collided on the runway. It was a catastrophic crash that killed around 500 people. And so he gave that analogy, and he really introduced the 2-challenge rule, where if you really have to at first speak up, and if you don't get heard, say it louder, and then if you don't, at that point, if you're ignored, you have to escalate and maybe even start shouting in some cases. So that's important. Safety is a big component of procedural care. In terms of the peripheral vascular disease burden, I really like this slide. It's a little markety for me, but I think it shows a lot of the key metrics that I really want to talk about. PVD is a massive massive issue globally, and it encompasses both arterial and venous disorders. In the heart, we're a lot of times we're in the arterial side, but this is a massive impact. 250 million people have PAD, and it's one of the most severe consequences, of course, is the amputations, which is what we're going to talk about today, and how to reduce those. So 50% of the people that undergo amputation, they die within 5 years. That's an overwhelming statistic. Another thing that folks may not know, if you have peripheral vascular disease, you're at a higher likelihood of having a myocardial infarction, even beyond someone with coronary artery disease. That's a really interesting statistic. So it's the most aggressive form of atherosclerosis. On the venous side, you can see that 50% of the people that have DVTs will develop long-term complications, and 2 million will have recurrent. 2 million people will have new or recurring venous ulcers globally. So this is a $10 billion healthcare burden, and that's something that we're tackling at Philips. So then how does this translate into procedural care? What we see is a fairly strong growth in procedures over the last 2 decades that really are driven by the expanded indications for the types and complexities of lesions, and also complexities in patients as well, higher risk patients. And these are potentially treated with percutaneous intervention. You could see that the volumes have been going up over the last few years, about a 5% or 4 to 5% growth rate in volumes over the next 5 years as well. So in the early 2000s, we really focused on single vessel short focal lesions, and over the last couple of years, we've seen an expansion into more complex disease, including longer and multi-vessel segments. Yet, despite the higher access to the endovascular procedures, we really haven't made an impact on clinically important outcomes, like amputation is an example here. So we're demonstrating a number of annual amputations for peripheral arterial disease is really it's not plateauing, and it's actually increasing. So this is happening despite the better access to peripheral vascular procedures, and it's not a good scenario for the patient. So how can we make an impact in health outcomes for peripheral vascular disease patients, knowing what we now know about IBIS in the coronary application, where it's an important diagnostic adjunct? So the data on the coronary side is very abundant. We have a number of over 10 randomized control trials, and of course observational data, real world data from close to 2 million patients for Medicare as well. But it's been a pretty consistent theme on the coronary side. There's IBIS guidance is associated with a 37% reduction in cardiovascular death, a 19% reduction in target lesion revascularization, 29% reduction in myocardial infarction, and a 43% reduction in stent-related thrombosis. So if we can impact broad outcome measures in the PCI space on the coronary side, there has to be a way to translate that experience into the peripheral vascular space. So what does IBIS show us that really adds value to the procedure? When we compare it to angiography, number of characteristics where IBIS is clearly superior, and that's what we're showing here. This is a paper that just recently was accepted in Euro Intervention, so we're now waiting for the head of the print online link, and it's really showing that you could really better qualify the degree of the stenosis pre-procedurally. You could potentially size the vessel better. Intra-procedural guidance, you could choose what type of treatment modality you may ultimately proceed with. But this is all driven by these image findings that are much superior compared to angiography alone. You see evaluation of stenosis severity and plaque burden. You can look at plaque morphology that may impact the prognosis of the patient ultimately. Lesion length, guide wire orientation, particularly when you're talking about facilitating CTO crossing, and of course traumas and adverse events like dissections. A lot of times you'll finish the procedure, everything will look good on the angiogram, and then you'll run an IBIS. You'll see a deep dissection that could have potentially closed off the vessel subsequently. So let's look at an example. So here we have the angiogram from a superficial femoral artery, which shows patency, and basically the white arrow shows a very mild 30% stenosis. But then when you look at the ultrasound image, you see that the stenosis is actually 75%, and this could really impact the procedure if left untreated. On the right, again, we see a final angiogram post-procedure where that looks patent but under ultrasound demonstrated deep dissection that will likely need to be treated to prevent the vessel from abruptly closing. So these are all great opportunities to use IVUS. Initially, when I joined the peripheral team, I really was encountering a scenario where there was a lot of uncertainty as to what the levels of evidence is. And of course, that was really preventing guidelines from being generated. A lot of recommendations are based on evidence. Really, there was no way to present the body of evidence that would show IVUS has utility and is potentially efficacious on the peripheral side. So a lot of the discussions were really, should we start randomized control trials? What do we need to show? And in each vascular bed, this was a scenario that I thought was a little bit too premature, and I think we had a little bit of a different strategy. The first thing I did, of course, is to initiate a systematic literature review with Smith Center for Outcomes Research. It's a great institute in Boston, and Eric Sasemsky is my partner in crime, and he's been absolutely amazing in executing on all these work streams. But here we have a systematic review where we show that close to 100,000 patients in almost 5,000 studies that were reviewed systematically and appraised with the Oxford rating system, which basically appraises the level of evidence for a study. What we could see now is that over 70%, 79% here of the studies that we show have a rating of level 2B. Level 2B is the highest rating outside a randomized controlled trial. So this presents the body of evidence that we could present, potentially either in a roundtable or a guideline committee that potentially use this to base their decisions and recommendations. We registered the study in Prospero. This was just to add validity and to give more transparency as to how we ran that methodology. I think 3 separate operators were reviewing literature, and if there was disagreement, there was an arbitration process, but it was a really rigorous process, and I'm really happy that it actually is accepted in the Vascular Medicine Journal. So we're also waiting for the head of print on that paper. On the venous side, again, very similar scenario. Common themes here is that IBIS is really helpful for lesion severity, characterization, device sizing and placement, and various thrombotic related venous events. So in both vascular beds, we see that observational cohort studies are at the level of 2B, and that it gives you a number of studies that you could base your decisions on, and really, in a way, answer that question of uncertainty that we were seeing. What about emerging data in the U.S.? We quickly sponsored. I did not feel like we needed to wait for a randomized control trial. We wanted to have a more rapid strategy and faster results. We basically contracted the Smith Center to run a large Medicare study that looked at longitudinal outcomes in real-world patients. Medicare insures a majority of patients over the age of 65. So for peripheral vascular disease, this is a perfect target patient population. So this will be the majority of the patients that we would see. And luckily, Medicare also insures both the hospital outpatient centers and privately owned clinics, so OBLs. You could look at the data in various different settings to look at the quality in each one. And that I'm not showing today, but this will be published hopefully soon. The paper is going to go into submission at JAC. But ultimately, what we see here is an association between where IBIS was used as part of the treatment strategy. We see a nearly 32% reduction in major adverse limb events, and that's pretty drastic. And if you're used to looking at randomized controlled trials, seeing these type of confidence intervals that are so narrow, you're probably blown away, just like myself, who I wasn't really used to big real world data. So for me, statistical sampling, when you're talking about such large cohort of patients, you could have really narrow confidence intervals and be that much more certain in terms of the hazard ratios. That was a really big thing. So these outcomes, by the way, are also besides being substantial, they're also very long-standing. This is preserved over a 5-year period. Oh, this is they could be treated either with a stent, or it could be potentially drug-coated therapy or atherectomy as well, but not necessarily only a stent. Good question. These are only arteries. So this is the first study, and then the next one is the deep venous side. Again, you're seeing that common theme of really hard endpoints like thrombotic events or stent embolism and thrombosis. These are pretty impressive. This is something that we really never anticipated, that it would be at that rate. But it was fairly definitive. In this case, real world data, unlike a randomized controlled trial, you cannot show causality. You could only say it's associated, because I did not prospectively run this study. But the methodology that we ultimately implemented, Smith Center published on that methodology. They've had various discussions with the FDA about how to run the data for it to have a high level of validity. So that's something you could do. The last remaining thing is typically, since it's retrospective, it's hard to prevent bias altogether. But that's where you need to really be transparent about your methodology and statistical sampling. In this case, it was really impressive to see in this 20,000 patients having these particular reductions. And really, in the last 2 years, it hasn't just been the peripheral side. On the coronary side, we have even larger data. This is from AMGAD Mentias, and that was released, I believe, back in 2020, where besides the 10 RCTs they already had that showed benefit, and even in some cases mortality benefit, the question was, does that only pertain to the cohort of patients in the randomized controlled trials, which may have large exclusion criteria, so maybe really narrow populations. So AMGAD Mentias really answered that question definitively. He ran a Medicare data set in this case and was able to show a mortality benefit. The beauty of doing real world data is you're able to have a temporal trends analysis like he has here that shows you the utilization rates and adoption patterns as well. So pros and cons with real world evidence, I've kind of mentioned the fact that difficult to control bias, it's retrospective. And in some cases you're limited because there's no causality. So you're only able to show an association. But besides that, the things that I really like about it is you're able to have user taxonomy. User taxonomy is surge in the peripheral vascular space. Multiple different disciplines operate in that space. Interventional radiologists, interventional cardiologists, vascular surgeons, all of them treat peripheral vascular disease patients in lower extremities. So in that data set, I could parse out which users, what their utilization rates are, looking at outcomes. You could also look at temporal trends and utilization trends over a 10-year period if you wanted to. In this case, I think it was a 6-year period for arterial and venous. And then we're also able to run the coronary data and see how what was happening on that side. But for FDA really is big on this on real world data, much more so than academic societies. And you could see that the Modernization Act and the 21st Century Act really show strong support for using that, especially if you're a device manufacturer on the post-market side and on the pre-market side to justify your conclusions. So here's an example of temporal changes on the coronary side overlaid with large RCT data and guideline changes as well. So coronary is lucky to have these studies over the last few years. And you can see there's been really little impact from guideline changes and from randomized controlled trial data on actual utilization rates. And the question is why that's the case. I think Greg Stone answered it best, in my opinion. This was a Twitter poll. I'm not sure if folks are on Twitter, but if you're a researcher and you want to have an easy way to sample physicians, everybody's on Twitter now. I think most academic research organizations almost require you to be on Twitter. So in this case, 969 operators were polled for the survey, and you can see that a lot of the barriers are not really evidence, which is only 13% of the responses. It's really the cost to pay ratio, and that really comes from the way that the IBIS is reimbursed. It's the way it's reimbursed in the procedure, especially in the inpatient side, is it's bundled into the cost of the base procedure. So if you have an intervention or you have a diagnostic cath, you don't get paid extra for IBIS. This is just something that's bundled in. So you're always in a position where you're trying to balance the costs versus the patient needs, and this leads to this particular bottleneck where you don't have enough reimbursement, or the payment structure is just not working to incentivize IVUS use beyond given the evidence that you see. So again, a really difficult problem of multiple different cross disciplines. Would they agree on particular scenarios where IVUS use would be appropriate? That's something that we really tackled head on. We separated this into arterial and venous, and we appointed a steering committee that would advise us as to who these world experts are, and we put together vignettes for them to appraise the literature, kind of use the AHA-ACC scale on a level of 1 to 9, where 7 to 9 is appropriate, which is close to standard of care or class 1 recommendation. 4 to 6 is maybe appropriate, and of course 1 to 3 is rarely appropriate. In other words, don't do it. So we've had 72 questions total that we polled on. These 15 experts on the arterial and 15 experts on the venous side, and this is some of the responses that we got. On the arterial, you see that we basically separated the procedure into 3 phases: pre-intervention. So this is where you're looking at lesion severity, morphology, potentially vessel sizing. So pre-planning phase. Then you have intraprocedural guidance. This is where you may ultimately look at the lesion and decide whether you want to do atherectomy or a drug-coated balloon potentially. Maybe you want to use an implant like a stent. And then of course the post-intervention optimization stage is where you're looking at, is the stent optimized? Is there malapposition? So really looking at stent apposition for that side. But overwhelmingly, the experts really agreed that on the arterial side, besides the pre-intervention phase, all 3 vascular beds, iliac, SFA, and tibial, there was a large level of support for use of IVUS in all phases. On the venous side as well, venous side particularly, the adoption rates are extremely high. It's almost unethical not to use IVUS. This is a scenario, probably the highest utilization rates are actually happening on the venous side, not peripheral venous side, not arterial or coronary. So we had a satellite symposium at TCT, and again, another independent roundtable there. And the conclusions were astounding. We basically, folks were in favor of actually moving on with implementations. They acknowledged the benefits on the coronary side. And of course, with this new large data set from North America, they were really reassured by that. And of course, our methodology, that's something that we're going to test this year at the SCAI Roundtable, which will include 5 medical societies reevaluating our results. So I held the best for last in a way. A lot of the folks that are interested in technology here. So we really want to go through the evidence and then now look at the technology side. There's only 2 manufacturers for the peripheral vascular space. It's Boston Scientific and Philips. Our catheter is a solid state catheter. It's one that's triggered sequentially. It's a piezoelectric transducer. So you basically introduce current, and there's mechanical motion and emitted sound waves that propagate through the vessel. And here you have basically the specifications for that. Another way that you could do this is basically achieve the same purpose is having a rotational catheter where the transducer rotates around in a circle and samples the imaging, and then you could have to basically put that back together and generate an IVUS image. So Boston Scientific tends to have the rotational methodology. This is coming from a state-of-the-art paper that I mentioned earlier in Eurointervention. So this is generally, these catheters are named after the guide wire that they're compatible with. So if you see an 018 catheter, for instance, Vision's PV 018 is compatible over the 018 guide wire. So there's a representative image here, and you can see the field of view. Hopefully that's in this graphic. Max diameter looks like no. So the field of view, I guess, is in another graphic. I'll have to grab that figure next time. But in general, there's different frequencies. They tend to be 20 to 40 megahertz, and the field of views obviously can range depending on the sizing. Huh? So Boston Scientific. You mean which ones? So the top portion are the rotational IBIS offering. We're the only ones that have the solid state or the phased array, and then that's on the bottom.
When you apply that you actually have rotation.
No, we still have them. We still offer rotational. So, but they're not on the peripheral side. They're in the coronary space. And so one of the things about rotational is for you to they have to have an automated pullback. So they have to be connected to a device that pulls it back at a certain rate, and that's how it generates the image. For phased array, it's happening electronically, so you don't really need that pullback mechanism, which is very convenient. I think it's built for workflow. You do lose some resolution because of that, but as you saw from the poll, the time considerations are very in the operating room. Everybody wants to. Basically, there's a big time component that needs to be accounted for. Let me see if I could get it. So here are the guide wires for the rotational, and you can see you have anywhere from 014, 018, and 035. That's the larger vessels. It's down the middle, yeah. For the rotational, it's down the middle, and then we have both our Rexable catheters and the ones that don't go over the wire at all. And you can see some of the coronary catheters with different tips are also used. And then we have a Pioneer reentry device that's really interesting. It actually has a little needle on the side to facilitate reentry, and in some cases that's being translated over even into the pulmonary space where they want to sample potential tumors with that catheter. So that's really interesting.
The table shows rotational has higher frequency, smaller diameter, is that something related to the configuration or not necessarily?
That's been the trend. You know, the higher the frequency, the image quality is better, the depth penetration is lower. So you sacrifice with that. If you go to lower frequencies, you have a much higher penetration through tissues, and your field of view is larger.
It doesn't necessarily location of one species.
It doesn't really, it's regardless of whether it's rotational or phased array. Correct. I'll have to invite one of the design engineers. He's actually very local here, who could really cover the technology very well. For me, this was just something that I've learned off a chart, just like you guys. So so this systematic literature review, this is a state-of-the-art review. We've really looked at anatomical considerations, which obviously arteries and veins. It's where arteries have thick walls and small lumens. It's the opposite on the veins. You have thin walls and large lumens. So a lot of vessels can be compressed as well by arteries on the venous side. So we put together some general guidance for new operators, and of course, calcium scores. Calcium score quantification is a very important process now, whether you're on the coronary or peripheral side. And we've put together, we've basically highlighted some grading mechanisms to do that. This graph, I think I've already shown, where you have different characteristics in different areas where IBIS is maybe superior compared to angiography. Mainly, you could see that besides flow, which we have a surrogate for flow with ChromaFlow, but besides flow and contrast propagation that you could see on the angiogram, almost every other area, IBIS is way superior. Another case, I think some of these images are representative. You could see a dissection, post-atherectomy dissection on the left side, again, something that could be missed with the angiogram. Fibrofatty plaque, in this case, that may be amenable to drug-coated therapy. And you could also see a very flagrant stand-up malposition case that if you don't see it on the angiogram, for sure the patient's coming back, and something you want to avoid. And then this is an area, this is really one of our differentiators, virtual histology. I believe the data was validated with multiple different pathologists, 3 pathologists that had to agree with each other in terms of what they were seeing on the tissues, and they're able to generate this color-coded map and give you a little bit of the morphology. And this, you could even look at thin cap atheroma. You could look at potentially cases where the cap may rupture. As Zhongping Chen, last time he mentioned, a lot of the problems don't come from severity of the stenosis and occlusion. It actually comes from random rupture and then platelet aggregation and thrombosis on top of that. So this is one tool that is currently underutilized. I think there's a lot of room for it to be developed clinically and maybe even potentially translate over into the peripheral side. Also on the coronary side, we're able to co-register the angiogram and the IBIS image. Really, it's something that many expert operators don't really need to do. But when you do combine that, you could even overlay that with coronary physiology, something we call triregistration, where you could see how the pressure drops along the vessel and potentially have some, hopefully soon we'll have some guidance as to what the pressure drop actually means in terms of treatment decisions. But you could overlay that directly on the IBIS image as well and choose a reference vessel or reference size for you to implant your stent. So this is something that is on the coronary side, but I expect the peripheral vascular space to take advantage of that too. And that's really it for me, I think. Yeah.
So farmers have been around for many years with a very nice data and and you have similar data for OCT, international OCT data.
Great question. And OCT recently has been really popular. Obviously, the Illumian studies are generating the same rigor of evidence. They're launching large randomized control trials like Illumian 3, Illumian 4, and the guideline committees really they don't really differentiate between IVUS or OCT. It's really intravascular imaging. That's the whole category. There's pros and cons with each, as you know. The high spatial resolution on the OCT is pretty much unmatched, even with the high frequency IVUS catheters. There is loss of depth penetration, but that could be overcome with potentially that could be a hybrid catheter, for instance. You could work on something where you could get benefit of both. But OCT has been coming up over the last few years, and now many medical societies view them on the same equivalent to IVUS.
In the interventional community, from physician perspective, their preference one or the other, or young from
a lot of times, even if there is a preference, that's always superseded by what the hospital has and the access. A lot of physicians tell me that if they're at the university, they obviously have a lot of options. But once they go to the community clinic, now it's whatever you have there. And even in the academic center, it's a lot of times it's ultimately the department itself only has limited budget, so they purchase equipment over a 5-year period. And until that 5-year period comes, you don't really get to have a voice. But I'm sure there's some operators that want to do research on vulnerable plaque. Ron Waxman, for instance, he's interested in that topic. He may want a high lumen resolution and image there. In other cases, people just want to do a fast procedure. Again, OCT is an example. You could really pull the catheter back rapidly, and because it's light, it's not sound waves. You can generate an image really quickly. And so we obviously are also emphasizing workflow, and we're offering an alternative to that. So the way we deal with that is through phased array catheters. Co-registration could still give you length measurement. Length measurement is an important measurement. I think co-registration could phased array catheter with co-registration give you the benefit of both. And yeah.
Good questions for David. I have a question.
Sure.
So with IBIS, and so there's just wide variations of the users, the clinicians that are using IBIS and their ability to interpret the image data. So in that first study, you presented the Medicare sponsored studies. How much do you think the variance in the physicians in their ability to use IBIS? So in the later thing, you have these experts, right? So I'm assuming those weren't people doing Medicare, you have these studies. So how much does the variation in users' ability to interpret the IBIS impact these numbers? And if you were to try to segregate, physicians who are really good at using IBIS, have you done that to see how these curves change?
So this is a really critical question. I think that question's been answered much better with randomized data than it has with real world data, because that's one of the limitations of real world data. It's hard for me to parcel out lesion characteristics and user experience. But when you look at the randomized controlled data, and I'm talking about IBIS XPL and Ultimate study was recently released in TCT. And that study showed you that if you use IBIS in a discretionary fashion where the operators don't have any protocol mandated criteria how to use it, the outcomes are half, basically the adverse events are doubled compared to if you use it in a systematic fashion. You have specific criteria which they use to decide which reference vessel, which plaque, which plaque burden where they can implant that stent. And if they do that, they really reduce the rates. If you use IBIS, you reduce the adverse event rates by half. If you do that in a non-discretionary systematic fashion, you'll reduce it by another half, which was completely surprising. Everybody was surprised that systematic use of intravascular imaging is where you could improve the outcomes on another level, basically.
Follow up, how much, this is a real problem with CT evidence, minus two, it's just a lot of data for a human to interpret. So what are your thoughts about that?
So this is where we try to automate, and we try to incorporate AI, obviously machine learning, vessel contour segmentation. Some of our peers are a little bit ahead of the game, like Abbott, OCT as well, and we're all looking to make decisions absurdly easy. There's a big training barrier. There's a big learning curve for intravascular imaging, and that's actually in the survey. It wasn't really well reflected. I think we have that survey from Greg Stone. Let's see if I can find it. Not a lot of people will admit they're not sure how to use. Only 7.9% of operators. I think this is total BS. I think it's probably double or triple, and it probably gets diluted out into other responses.
Most people don't know where
But, right. Actually, yeah, exactly. The people that don't know are probably not even captured in this. Good point. So this is a really big barrier. I think we have a number of educational campaigns to educate. Even this year with Sky, we're hoping to lead a symposium on training both scenarios where it would be appropriate to use, and also if you do use it, standardized image interpretation, help them make the right decisions in terms of what is the current thought process on that.
Another question I had at the very beginning, you mentioned surgical, not intravascular. What are
Just go ahead, please reiterate the question just so the Zoom audience can hear. They're losing some of the words.
Okay, great. So hopefully they can.
Yeah, real early side. You had surgical procedures showing growth of intravascular. Just wondering, surgical, what are they?
Oh, it's just, yeah. Basically, you could do the same vessel. You could treat percutaneously, or you could do it with open surgery. You could bypass the same vessel, but they're targeting the same disease, same lesion. You could just do it, and really, this graph really shows you as we've had an adoption and growth in percutaneous surgery, surgical intervention has gone down. The only challenge is we would expect to see lower amputation rates, and we have not seen that. So now we're trying to. This is a perfect opportunity for IVUS to make a dent in amputation rates, because as we saw at least from the CMS data, it's a pretty substantial impact on amputations. This is the hazard ratio is 0.82 with a very low confidence interval. So IVUS has an ability to impact hard outcomes, and it's able to do that in all phases of the procedure, and also able to do that in both vascular beds.
The follow-up with diabetic, those patients, they are not recovering from nasal exercise. It's the micro temporary somehow.
So diabetes is the #1 risk factor for peripheral artery disease. Patients with diabetes, they have a 3- to 4-fold increase in having peripheral, in likelihood of developing peripheral vascular disease. So this usually starts with microvascular disease, and then by the time you have already, in the coronary side, we call it epicardial disease, or large vessel disease on the peripheral side, lower extremities. By then it's already developed, and now you're just trying to slow it down. You're not, correct.
Yeah, I just want to follow up to the question. Like Dr. Chalyan mentioned that IBIS has been there for a while, and OCT has really been managed by acoustic, even fluorescence. I wonder, like, from the industry perspective, how you guys can adapt to new technologies. What's a business model? Would you rather to acquire like a small company and with new technology, or we rather
That's a good question. We do both, obviously. We have in-house what we call organic innovation, where we develop the technology in-house. We also have inorganic innovation, which is we either partner with startups. Sometimes we don't right off the top buy them. We may have milestones as to how we partner with them, but we do both. And as you saw, sometimes a company like ours is really big, so we do a lot of things at the same time, and we may be much slower than a startup. A startup could rapidly develop technology, could rapidly get it to clearance. That's one of the things I specialize in, is being able to support our pre-market and post-market strategy. But a startup has much less restrictions. A lot of times they move faster. We become a late adopter, but at the same time, we may own the ecosystem in the endovascular suite. So by the time we're a late adopter, we already have much better, like we have feet on the ground in terms of sales, supply chains are worked out. So for us, it's much easier to push that technology.
Okay, so what do you have in there? What's the best way to work with you now? Okay, yeah. Could you repeat the question?
Sure. So what the question was on the academics, how would they collaborate with us? That's a really great question. We have a portal, by the way, investigator-initiated research. So if you have an idea that you believe is in line with what we're doing, or with what Philip's business interests may be, or what we're looking at, you could submit. It's almost like a 1 to 2 page paper. Karen actually is right here with me, so she is basically in charge of our IIRs, investigator-initiated research submittals, and she presents that to the committee. There's a committee of review for it, very similar to an academic setting, and then they make a decision and they send you a decision based on that.
We have Zoom people. Do we have any Zoom questions?
Would that be in the chat?
Yeah, please just,
okay. Folks, any questions from the Zoom team? I'm going to try to get this to the chat in a second. So I should probably exit out of the. Let's see.
It's okay, just reshare it.
Okay. So if folks want to type their questions in the chat, I could re-ask them, or if they want to turn on their mic and also ask, that would work.
So David, this is Rashmi. Great presentation here. What is next after this? What is left to be done to make IVUS standard of care? What is the thought process? What more needs to be done, and how complex does that look?
Sure. I mean, that's a great question. Ultimately, I can't answer that question with a high degree of confidence, but at least we have some working blocks that we've generated over the last year, where we've had agreement on scenarios where IVUS would be useful, something we were looking to get endorsed by medical societies. So once we have that endorsement on the peripheral side, I think that's going to be a major step, and it will also give us a pathway as to what other evidence is needed. Is it going to come from an observational study? Is it going to come from more training, or is it going to be a randomized control trial? We'll have much more visibility on that once we have that. Once we have these separate roundtables with medical societies. Did that answer your question, or?
Yeah, no, that's great. Thank you. It seems to be a longer process, but again, a smart method to get there without having to burden from the very beginning is what we hear then from you today.
Exactly, and there's also, of course, reimbursement challenges. That's one of the benefits of real world data, is actually a lot of the payers, both institutional payers and private payers, they want to see that level of data in their decision making. That's something we'll be looking to test with CMS directly. But reimbursement, as you saw from that survey, is a #1 challenge for this technology.
Yeah. Great work. Thank you.
Thanks, Rashmi. Any more questions from Zoom? Great. Thank you very much.